You're now listening to MedEd Talks Rheumatology, a Vindico Medical Education production. To view CE information and claim credit, log into mededtalks.com and search Lupus Nephritis, Advancing Equity in Care and Research, or click the link in the notes section of this podcast. Now, here's your host, Dr. Sam Lim.
Hello, and welcome to Lupus Nephritis, Advancing Equity in Care and Research. This continuing education activity is provided by Vindico Medical Education and is supported by an educational grant from Genentech, a member of the Roche Group. I'm your activity chair, Dr. Sam Lim, professor of medicine and epidemiology and associate director in the Division of Rheumatology at Emory University, as well as chief of rheumatology for the Grady Health System in Atlanta. And today I'm joined by my friend and colleague, Dr. Jason Cobb. He's an associate professor of medicine in the Division of Renal Medicine at Emory University in Atlanta. Welcome, Jason. Glad to have you as always. During this 3-episode series, we'll discuss disparities in lupus nephritis care, the importance of equitable access to care, and strategies to improve diversity in clinical research. In this episode, we will be discussing access barriers faced by patients with lupus nephritis and strategies for coordinating more equitable care. Thanks for joining us today, Jason. Let me start with this. From your perspective as a nephrologist, what do you see as the biggest barriers to providing equitable care for your patient with lupus nephritis?
Biggest barriers include access to providers, both rheumatologists and nephrologists. Oftentimes we see lupus nephritis patients who are in acute lupus nephritis flares, but we often only see them in the hospital for emergent issues. They're fluid overloaded. They have nephritis syndrome. It's very hard sometimes to see these patients on a continuity basis in our clinics. So having access to both rheumatologists and nephrologists. But also when they're first diagnosed with lupus and have signs of lupus nephritis being seen by their rheumatologist, we need to get them into nephrology clinics faster. Oftentimes, we are months out for new patient appointments. And I know for me, as a nephrologist with an interest actually in glomerulonephritis and lupus nephritis, I've improved in communications with my rheumatology colleagues. Just call me directly, and we can get patients in a lot faster. I feel like all patients with lupus and concern for lupus nephritis need to be seen in a timely manner. But that we have social determinants of health, things such as insurance, lack of insurance, underinsured, transportation needs that we often see in our patients, which once they get into your clinic, keep them from coming to your clinic on a regular basis. Ability to afford medications, patient education. I think when patients are fully educated about their disease process, it's better for that patient and their ability to comply. They understand the importance of being seen.
I think you touched on this a bit. Thank you. In your practice specifically, what's worked to streamline referrals and reduce delays in getting patients with suspected LN to biopsy and treatment?
So I have developed a glomerulonephritis clinic, which predominantly sees patients with lupus nephritis. So we're lucky to have a specialized clinic, but built relationships with the rheumatologists at Emory University that they feel comfortable reaching out directly through messaging, with phone calls. I actually leave spots in my schedule for potential new lupus nephritis and glomerulonephritis patients. Also, we work to collaborate and see these patients together. So oftentimes, if a patient cannot be seen by rheumatology or nephrology, we'll alternate months. So it'll be easier for the patient to get coordinated care. For us, though, kidney biopsies, once ordered, we have a pretty good interventional radiology and also with our fellows, nephrology, ability to get patients in for kidney biopsies. So I think the main thing is getting them into the nephrology clinic faster, then we can get the kidney biopsies done pretty soon. Now, sometimes we do have delays with patients between work, childcare, other things. So some barriers, and there are delays sometimes with patient factors that sometimes come up. Life happens. but we try to work around those things and try to get these patients biopsied as soon as possible.
Yeah, I can attest to how accessible you've been. And, I just want to formally thank you for that. Because it's not uncommon for you to shoot me a message in the system, oftentimes a quick text. And, it's not overwhelming and you're so conscientious of my time. But a quick question, I have Mr. So-and-so right in front of me. And there's a question that helps so much with the patient perspective. I mean, it's not just even clinically, we're getting together, we're figuring out a plan. But the fact that we have a unified front, we have direct communication, it's quick and efficient for the patient. I think that really helps in terms of adherence, obviously outcomes, and reducing disparities, which is what we're talking about.
And I think our biggest success has been in the last 3 or 4 years when we wrote the grant for the Lupus Nephritis Patient Navigator Program. And now that program has now been taken on by the Lupus Foundation of America, Georgia chapter. So I actually just referred a patient to our Lupus Nephritis Patient Navigator on yesterday. So a patient that we're seeing in clinic actually referred from rheumatology. We actually know the patient lost insurance, so we was able to see the patient with charity care in my clinic. But we still need assistance with medications for this patient and also with transportation to appointments. So hopefully our patient navigator could assist that patient.
And I have to bring up this thing that came up in the other podcast is that these barriers that lead to disparities directly lead to disease activity and flares. So this is a clinical issue for us. So as much as we may feel sometimes that we're being pulled out of or away from our clinical training, this is part and parcel with what we're trying to accomplish, is to reduce flares and improve outcomes in our patients. All right, next one. Can multidisciplinary or co-located care help address some of the current disparities that we see in our field?
And I think we can learn from each other. Definitely with our patients with lupus and lupus nephritis, I'm definitely very comfortable with the lupus nephritis part, but the extrarenal or other manifestations, we definitely need each other, and I definitely need the assistance of our rheumatologists. But also I think there's differences too in the way that we may approach part of their overall lupus. And I think working as a team definitely address that. And especially if you have the ability to create a specialized clinic like we have, where we see a high amount of patients with lupus nephritis and built relationships with rheumatologists, I feel like that helps with access to being seen, access to getting faster kidney biopsies, but then access to treatment and also access to new treatments and ability to participate in clinical trials.
If a practice doesn't have the resources for a dedicated LN clinic, are there any simple steps that they can take to foster better collaboration?
So I think it took us some years to develop more of a specialized clinic, but I think it just building a relationship, meeting, having lunch, talking to the nephrologist and the rheumatologist together. I think breaking that barrier and forging relationships and ability to co-manage. I think when it comes to kidney biopsy and certain treatments, I think there used to be maybe difference of opinions between nephrology and rheumatology, but I think after working with each other so long, we've come to a consensus on treatment and our process about getting patients in for biopsies. So I've definitely seen the approach to taking care of patients improve, but also I think it just started at the beginning just by us building relationship and the nephrologists and rheumatologists talking to each other.
Yeah, that's a good point. Yeah, we've talked a bit about where we are now, you and me, in terms of our institution and our patient care. But you're right, it did take several years. And so I didn't want to imply by any means that this was simple in terms of simple steps or something will happen very quickly. There may be some low-hanging fruit to improve aspects of this. But it is a simple approach that often just takes some time, like you said, and reaching out and gaining that relationship. And like any relationship, it takes time and effort. And I appreciate that about you. Can you share a case where co-management between nephrology and rheumatology changed the trajectory of a patient with LN?
There's so many examples, but one that definitely comes to mind is a recent one. Young African-American male, recently diagnosed with lupus and lupus nephritis. Actually had lupus nephritis during his initial presentation with lupus in the hospital. Very young guy in the early 20s, and someone who was completely healthy before and now having a new diagnosis of lupus and also lupus nephritis, it definitely was difficult on him. But this patient just wasn't responding to therapy. Actually, we think he was pretty compliant with taking his medications. We went through mycophenolate. We went through cyclophosphamide, and he was still having extrarenal manifestations plus significant lupus nephritis. And certain things nephrologists are more comfortable with, and there's certain things that rheumatologists are more comfortable with. I think y'all have been using belimumab at least a decade before the indication for lupus nephritis. And as a nephrologist, and we see a lot of kidney transplant patients, we've been using calcineurin inhibitors for decades, and so medications like voclosporin we're very comfortable with. So I think when it's time, especially initially, getting patients on belimumab, I definitely needed the rheumatology support on dosing, side effects, etc. Then this patient, when he responded, even in his maintenance phase, was not in complete remission, we decided to go mycophenolate and voclosporin, and I definitely helped with the dosing of that and how you manage following patients on voclosporin. So I think that's an example of many examples that we have, that we all are taking care of the patient as a team, but there's certain things that one is more specialized in, and we work well together doing that. Now this patient is in complete remission, even though it took us about a year to get him there, but I think we're proud of the effects that we had in that patient. And also he has been referred to our lupus nephritis patient navigator, and he has participated in some of the education events with the Lupus Foundation.
Thanks for that. Great information. From your perspective, is there anything we can do to promote collaboration within care teams, like with our APPs, medical assistants, or office staff to help coordinate, deliver more equitable care?
Just getting everyone on the same page, educating the patients, also educating the staff about the importance of patients being seen in clinic. These are not stable CKD, chronic kidney disease patients with diabetes or high blood pressure. These are patients who could have acute flares, severe nephrotic syndrome, who need to be seen on a regular basis. So we need to get from the front desk staff helping us with patients who miss appointments. We're helping us with referrals to get patients in faster, with our medical assistants and nurses when it comes to patient education about the disease process, and also patient education about new medications we start. One thing that we're looking forward to is trying to get a pharmacist also who can help with these new medications and help educate patients and follow up patients with side effects of these medications we're using.
Yeah, that's a great point. We can't forget about our pharmacy colleagues for sure. I'd like to close by asking you one final question. If you had just 30 seconds in the hallway with a busy nephrologist or rheumatologist, what one action would you encourage them to take tomorrow to help reduce disparities in lupus nephritis care?
I will say build a connection with the other team. So you're a nephrologist, build a great connection with rheumatologists. If you're a rheumatologist, if you don't have a relationship already, find a nephrologist that you can build a relationship with. And if you don't have anyone locally, reach out to specialized centers. Like myself, I see patients from all over the state of Georgia where nephrologists, actually I get referrals from other nephrologists and also referrals from rheumatologists. So just build relationships with other providers, I think will really help your patients.
And with that, I just want to thank you, Dr. Cobb, for your excellent discussion and your insight. And I want to thank you, our audience, for listening. Please remember to take the post-test and evaluation to receive continuing education credit, and to tune in for additional episodes in this series.
Thanks again for listening to MedEd Talks Rheumatology. CE credit can be claimed through mededtalks.com. For other episodes in this series, search for Lupus Nephritis, Advancing Equity in Care and Research.